All right.
Okay, we're going to let people in. Is that all right?
Yeah.
Ready to roll?
Sounds good.
All right. Here they come.
Thundering herd.
Well, they're pretty quiet because many of them are muted. Welcome, everybody.
Mm.
We've had some setup issues.
Yeah. And, you know, you did a good job trying to avoid those, and they still happened.
I know. That's why we always try to start early with the speakers.
Well, we were here, but we were playing with our computers.
Well, I know that's it. It's generally the computer issue
Yep.
that gets in the way.
Mm.
It's not uncommon.
So what I was going to start, and then Karen Ayers will speak next, and then Joni McAtee, and then I have a little thing to finish up at the end. So
That's fine.
okay.
What we'll do is be going through a series of slides about OLLI, and then I will introduce you, and then it will be all yours.
Sounds great.
All right. Dane, go for it.
All right.
Over there, where you're more comfortable.
No, I'm fine here.
You
That's
sure?
fine.
This.
Okay. Just to let everybody in this Zoom room know that we record all of our brown bag presentations. So I'm just giving you a heads up that we will be recording in about a second here, and then we'll begin. Just trying to find it.
It is recording.
Oh, it is recording.
Yes.
Perfect. Okay. Then welcome into this week's brown bag presentation. It is the last one of spring, so I'm happy that you are all here. Welcome in. We're going to start this presentation with a land acknowledgement. We acknowledge that Cal Poly Humboldt is located on the unceded lands of the Wiyot people. Arcata is known as Gudini, meaning over in the woods or among the redwoods. We honor them and all our neighboring tribes by our ongoing commitment to developing trusting, reciprocal, and long-lasting partnerships. Here at OLLI, we believe learning should never end. OLLI creates opportunities for academic engagement, civic involvement, personal growth, and fun. By offering a myriad of classes and experiences for a vibrant community of learners aged 50 and better, OLLI delivers learning for a lifetime. So the way OLLI works is it's a membership program, runs from July 1st through June 30th every year, and then primary memberships are $35 a year. OLLI classes are designed for lifelong learners, 50 and better, but if you're older than the age of 18, you can join us as an OLLI member as well. Non-members pay an additional charge and are enrolled as the space allows. But there are some benefits to being an OLLI member that I want to tell you about. So if you're an OLLI member, membership includes lower class fees and first priority registration. You get a Cal Poly Humboldt email account, which gives you access to the full professional version of Zoom, as well as a whole list of other types of softwares and internet tools that are offered by the university ITS page. You also get a discount on the Jack Pass. You get eligibility for course scholarships. You get student discounts at local businesses. You can participate in OLLI special interest groups. You also get a free library card, an ID card access, which gives you library access. And you also show that to the different businesses around Humboldt County for the student discounts. And last but not least, you also, with your membership, get gym and rec center access with a small fee.
And last but not least, you do get invitations to brown bag lunches.
Yep. Every Wednesday and Monday morning, we send those out so that people have access to the links. And right now, I want to talk about Let's Connect. It's with Tracy Barnes-Priestley. It's a free weekly chat via Zoom on Fridays from 10 to 11 a.m. These weekly sessions, which began early in the pandemic as a response to the isolation brought on by COVID-19, has grown to become a regular gathering of friendly and interesting people. This hour of conversation focuses on a new topic each week, and it's time for sharing stories, thought-provoking experience, just trying to be a community, talking to each other, and So this next one upcoming May 2nd, the topic is, what are your thoughts and feelings about artificial intelligence? If you want to know more about Let's Connect, you just visit our website. It's extended.humboldt.edu/olli/Let's Connect. And if you go to our page, there's a tab with Let's Connect information on there too. Like I mentioned earlier in the presentation, we do record all of our brown bag presentations and upload them to our YouTube channel. So if you ever miss a brown bag presentation, or if you want to check out previous ones that we've made in the past, go ahead and visit www.youtube.com/@OLLI Humboldt. And if you have any questions or concerns about OLLI programming, classes, events that are upcoming, please give us a call at 707-826-5880, or you can email us at olli@humboldt.edu. And just as a sneak preview, so right now we are getting ready for the summer session. And the date that I wanted to let you know about is,
June 30th.
June 30th. We are having another brown bag presentation, which we will have the instructors for the summer term each give a brief presentation of what their class will be. And it's a great way, if you're interested in the summer session, to learn more about what classes we have to offer. So mark that on your calendar. And without further ado, I'm going to pass it over to Jane, who is going to introduce our speakers for today. Jane?
Welcome, everybody. I'm delighted you're here. And because this is our final brown bag lunch program session for this session, this spring. And I want to mention that we normally have an in-person open house. And what we're doing instead, because the summer session is relatively short, is we're going to do it online during the brown bag lunch program slot. So you can come. We'll have as many of the instructors who decide they want to participate there. They'll be able to talk about what they're doing, and you can ask questions in the chat, for example, or in person. I mean, immediately. I need to tell you up front that I selected this topic because it became very relevant. I and two of my neighbors all experienced the loss of our spouses within 1 year. So it was a pretty rough time for all three of us. And what we didn't know or did know about these services available and how we experienced them was very important, particularly the issue of how do you recognize when, if your spouse won't make the decision you need to, because death is approaching, whether they want to acknowledge that or not, and when you need to step in. It's a tough situation. It's a tough experience. But the more you understand about it and the services available, which are wonderful here, that's what this is all about. And feel free to put questions in the chat as you have them. There will be a time after each speaker. Dr. Mahoney is going to be first, and Karen Ayers will be second. But you can put your questions in the chat anytime. And don't be shy. It's important to understand what your options are. So without further ado, I want to introduce you to Dr. Ellen Mahoney. Since 2010, she's been the medical director of the cancer program at St. Joe's, and she has served as the medical director for St. Joe's perioperative services since 2007. She's a former interim medical director for Hospice of Humboldt as well. She trained as a surgeon at Stanford University after graduating with her MD from there in 1981. By 1986, she had risen to become chief resident of surgery at Stanford before going on to become a board-certified fellow of the American College of Surgeons in 1993. While in the Bay Area, she founded Bay Area Cancer Connections and founded its offshoot in Humboldt County in the breast and GYN health program. When she moved to Arcata in 2000 and opened her own practice in breast cancer surgery. She's had several medical directorships in Eureka, including operating room services, hospice, inpatient palliative care, and cancer care. she's very diversified. She's touched many, many areas in our area and in the hospital. But increasingly, her time is spent in continuing to develop the cancer care program to provide services in diagnosis, treatment, and integrative care for cancer patients in Humboldt and Trinity counties. She speaks frequently on breast cancer to community groups and serves as a medical editor and expert contributor to the website of the Susan Love Foundation, a nonprofit organization dedicated to the prevention of breast cancer through innovation, education, research, and advocacy. She's a fantastic advocate. And Karen Ayers has been a nurse for 36 years and a nurse practitioner for the last 22. After graduating from UCSF with her master's in nursing in 2003, she worked as a nurse practitioner with people with serious kidney disease for 8 years. She transitioned to working for Hospice of Humboldt as a hospice nurse practitioner and to working as a hospitalist at St. Joe's. Her work evolved to have a focus on serious illness and palliative care, and she now works for hospice as both a hospice nurse practitioner and as a clinical director of its home-based palliative care program. Along the way, she completed a postmaster's program in psychiatry and mental health and became certified as a psychiatric and mental health NP. She has a newer love in her life grandbaby, Asa, who has just turned 2, and an older love in her father, who is journeying through multiple serious illnesses, including cancer, as he enters the end stages of his life. And she will be talking about that period. Okay, it's all yours, guys.
Okay, we have a third person. We have Dr. McAtee, who's a Hospice of Humboldt doctor, here with us also, and she will be speaking after Karen Ayers. So we were given this topic of, how to tell how things are going. I decided to back up a step and talk a little bit about what people expect when they get a serious diagnosis, or a diagnosis of something that's going to require treatment that they never had in their life plan. And the questions that are being asked vary between the provider and the patient. The patient is saying, how serious is this? Am I going to die? The doctor is thinking, how much information do you want? What's my best educated guess about how you might do with treatment, et cetera? So it's very important to let your doctor or other healthcare provider know how much information you want and how you best receive information. And it's not going to all come at one meeting. It's got to come in over time as you build trust and communication. So hopefully you all have that. But here are some things to ask. I think that it's always a good idea to get a copy of whatever pathology report is causing the problem in the first place. The federal government, in its wisdom, made our electronic medical records all electronic some years ago. So now a hacker could get in and just destroy your pathology reports or your medical records altogether. So important things, it's good to keep on paper. So what I tell my kids is, if somebody does a biopsy and takes a piece of you, make sure you get a receipt. And that receipt is the report. And that report will have in it the type. It may or may not have stage, because often that's not known at the biopsy. It'll have grade, it'll have tumor markers, and increasingly treatment of cancer is being based on changes in the DNA inside the cancer cells. It's all like CSI. You look at the DNA inside the normal cells and the DNA inside the cancer cells and say, what changed? How did this cell go rogue? Well, and then we also need to put into the discussion about treatment options, how healthy you are and or your relative is, and how you respond to treatment, which of course we don't know. But rather than a diagnosis looking at the big picture for, like, am I going to be alive in 20 years? Recognize that you're alive today and make the most of it, that there won't be anything happening dramatically quickly. So the other thing you want to know from the first doctor that's giving you the news is to describe the treatment. What are the side effects? What are the financial and legal implications? Because finances are becoming increasingly a problem with financial toxicity is what we call it in the cancer program. But what people really want to know is this a long shot deal, or do I have a good chance of a cure? And that's where, you have to be a little bit sophisticated about how the information is given. And you have to realize that the doctor is dealing from maybe a different perspective than you have, and you have to make sure you're on the same page. So one thing to remember is that survival statistics, first of all, come in several flavors, and I'll go through those in a minute, but they're always based on percentages, meaning they're always based on a population. Our ability to tell any individual how they're going to do is very limited in most cases. So if you say, if you've got pancreatic cancer and you have a 5% chance of living 20 years, that means 5 people out of 100 live 20 years. It's when you have a mammographically detected hormone receptor positive breast cancer, we give you a greater than 95% chance of being cured by your first course of treatment. So, it depends again on the type and on the treatment that you're going to have to undergo. One thing that comes up is people want to know what happens if I don't do anything, and that's almost never a good thing, because you end up with wound complications and other things that we rarely see because people do get treated, and we don't have any alternative treatments that work as well as the treatments that we have that are based on clinical trials, where we have meticulously over many decades developed a plan of care based on the best treatment we have, and then the best treatment we have plus something else. And slowly by slowly, we're sort of improving our care. There are several kinds of survival. There's cancer specific, like, will this cancer be gone in 5 years? Relative survival, and that's death from anything. Overall survival, in terms of the death from breast cancer over a longer period of time. And then progression-free survival, which is sometimes used in clinical trials. It just means that the cancer hasn't moved it and shown itself again. So if you're interested in cancer statistics on a system-by-system basis, go to seer.cancer.gov, and they have cancer statistics by site. And but it shows you that all prognosis that we give is behind the times, because it takes a long time to get all the data in and have things happen. So the current SEER data was the 2016 data. It was updated in 2020, and we're still waiting for the next update. So we can tell you how people did back in 2020. We can't tell you how we're going to do with you in 2025. But the one question your doctor can probably not answer, except in the most extreme cases, is how much time do I have left? It's a tough job, and one of the medical oncologists that I know up at University of Washington has a good saying, which he says, he found himself thinking when he was confronting a new patient, if I paint a rosy picture, do you promise not to cry? And that's misplaced kindness. You owe people honesty, and you owe them, this is a long shot or this is a chip shot. And, we can make a good guess at that. And then what are the different treatment alternatives? So that is my, let's see. Yeah, so, when people want to talk in stages, like I said, sometimes that's misnamed denial, but it's not. It's denial is saying, I'm not ready. This is too scary for me. And we hope for the best. We set realistic goals. We need to see how people tolerate treatment to know when to start. And Karen is going to talk about when to stop.
Hi, can everybody hear me all right? I'm going to share my screen. I have a few PowerPoint slides. And I just want to send the camera over to Dr. McAtee for a second. So let's see. but she's here too, and she may chime in on some of the things that I'm talking about as well. Okay, let's see, there's the share button. Okay, so I titled my part of the presentation Decision Making in the Serious Illness Journey. And I think we are mostly talking about cancer here, but this can apply to people who have other illnesses, such as the late stages of heart disease or lung disease, or something like ALS, a neurodegenerative kind of condition. So just for what that's worth, this is sort of general stuff. So how do I, meaning you, know when it's time to talk about stopping treatment? And my response as a palliative care person, maybe meeting with you, would be, what has led you to ask this question at this time? So how have things been going for you recently? What are the changes that you've maybe noticed? And then how is coping with demands of the illness going for your person, for you, if you're the caregiver? So those are the things to think about. And I kind of to just open it up for just a second, if it's okay, to see if anyone wants to chime in on this here and bring up a particular example you might be going through or you have gone through, and just tell me what kinds of things that you have experienced that might lead you to ask a question like, how do I know when it's time to talk about stopping treatment? Does anybody want to do that?
I'll chime in. When my husband was dying, the problem was that he had both cancer and Alzheimer's, and part of his Alzheimer's included not being able to recognize that he was ill, either with Alzheimer's or with cancer. And that made his denial very difficult for me to deal with, because I wanted him to be able to give me his opinions on what treatments he wanted to do. And he wasn't able to acknowledge that he was ill, let alone that he was dying. So it pretty much fell to me. And I did find some particular resources that I'll be glad to share if somebody's interested on how to navigate that in particular.
Yeah, great. So that was a lot of coping on your part, right? Because your partner, your husband's cognitive ability made his coping kind of maybe a little on the unrealistic side. Yeah. Mm-hmm.
Okay, I'll chip in too.
Okay.
My husband had 4-stage cancer when diagnosed. Okay. And I remember my doctor saying, you need to have the talk. Well, if somebody doesn't want to have the talk, that's an extreme problem. I remember one doctor saying, well, the least you can do, because he had also brain cancer, and he said, at least get rid of the big lesion that was golf size in his brain. And then basically didn't say, and then we can do radiation, and then after that we can do chemotherapy, immunotherapy. So we did do that, and it was looking quite positive that, I mean, the radiation worked. The surgery followed by the radiation got rid of 2 of the tumors, and then reduced the other one in half. And then the immunotherapy, which was a new one, with the promise of giving him maybe 1 to 2 more years, started. The problem was, and what neither of us really discussed sufficiently, and he didn't want to talk about it, was that he was having a terrible time. He'd already lost a lot of weight, gone from 100 and 45 or 50 down to 118. And he started being unable to eat. In other words, the minute he ate, within 5 minutes, 10 minutes, he got all gassy and bloated, and it was terribly painful. So he had to quit eating. He wanted to eat, but literally it was too painful. And that aggravated the problem. And I mean, we had medications. What I finally understood was part of the shutdown process is that your peristaltic action quits working. And you have all these meds to give them to try to make it work, but it doesn't work. And then when we got to when he literally couldn't pull it off anymore, he ended up in the hospital. And then the issue was tube feeding him versus not tube feeding him. He refused to talk about it, what he wanted. And we went through literally 4 sessions meeting with the palliative care staff, who are wonderful. But he waited literally till the last day. I mean, they tried to say, you might want to think about this. He didn't want to talk about it. Until the last day when he said, I want to go home. It was too late. He died overnight.
Yeah.
Well, he didn't die overnight. He was comatose. So somehow, even though we had everything set up in our advanced directives, I don't want this if there's no hope. No doctor said to him, or did the palliative care people directly say, there's no hope, get yourself out of this position, stop. Nobody was willing to say that to him directly. So I ended up having to say, pull the breathing tube, pull the feeding tube, etc. So regardless of whether you have done the right thing with your advanced directive, somehow you have to get the conversation going with your spouse to acknowledge that they're not going to make it. Let's make it as smooth a transition as possible. The hospital staff were fabulous, okay? But it was then too late for hospice because you would have not made it to that far. But it's really so important to deal with your good friend or your spouse, and to deal with yourself and your hesitance to take control when you can see what's going on. But first you have to understand what's going on, and you have to push the doctors to say, tell him he's passing. Let's figure out how to do it peacefully. And that's why I set this whole thing up, because people, even though they have an advanced directive, they don't, it's not that anybody's stupid. And at the point they get toward the end that they can't even talk. I mean, they're too weak to talk, or there's too much going on and they're coughing up stuff. And I mean, it's terrible. So, I mean, you don't want to go through that, and you don't want your spouse or your friends to go through that. So I want you to take this to heart, to make it, I mean, my friend Anita had a tough passing. Her husband was a doc. She's a nurse. So it's a very difficult time, and you can make it less difficult if you can deal with your friend or your husband honestly, and the doctor is willing to support that.
Yeah, those are both very powerful stories. And I just want to say that, we know that there are some cancers that we don't make much headway on, and brain cancer is one of them. Pancreatic cancer is another one. We have some treatment, we can buy some time sometimes, but the outcome is sort of assured from the moment of the diagnosis, as opposed to breast cancer, prostate cancer, lung cancer, colon cancer, many of which can be screened for, that we can get it earlier and we can give you a better chance at survival. So I was disappointed to hear that nobody would say when he was in the hospital that it was hopeless, but you did exactly the right thing by him because it was hopeless at that point.
Well, I want to try to get this topic out there so doctors will be forthright. The palliative care people will really talk about it directly to the person. And basically, I mean, he wasn't stupid. It's just nobody wants to push. And
Yeah.
honesty that's required is important. He had melanoma, by the way.
Okay.
And that was even a
Yeah,
worse
that's
cancer.
a tough one. Yeah.
Yeah.
So let me keep moving here. Maybe some things will come up for you. Okay. So, let's see. How do I get this out of the way so I can see my slides? We don't have the best computer setup here. So, when I'm having a palliative care discussion with, say, a family or a patient and their important people around them, I really want to know who we're making decisions about. So I want to know about this person. Tell me about this person because a lot will be illuminated there. I also, again, as Ellen was saying, we kind of want to know, how do you like to receive this information? For example, are you hoping for recommendations from us? And so knowing about the person really helps in making recommendations. And I might throw out some other questions, say, what would happen if we did stop treatment or if we continued treatment, for example? And then I really like to talk about the value of things. And for me, what value is, the value equation is what you get for the cost. So it has nothing to do with money necessarily, but you want to have good return if you are putting a lot of investment into this particular, say, treatment that you know you're going to lose all your hair and you're going to be sick to your stomach and you're not sure if it's going to work and those kinds of things. That's a high cost for you. So these are the kinds of things to really think about as we're trying to make a decision about which way to go. The other thing that's important beyond kind of those who we're talking about, but what is important and what matters most to the person and to the people involved with that person. What makes you happy? What kinds of things that you would fulfill, activities, experiences, maintain are most important for you to feel like your life has quality or you are living well? Those are important things to really start talking about early in this whole journey. Particularly the people who are going to support that person, because as Jane just told us, sometimes we get to a point where that person doesn't seem to be making decisions that are consistent with what you talked about before. And in Anita's case, that person can't make those decisions. So sometimes you have to be the one who stands up and says, wait a second, this is what we talked about before. So what fears or worries do you have about your future? Also another important thing to really get out there on the table. What's worrying you? What's concerning you? That kind of thing. There's a couple of, I call them data-ish things that also might influence decisions. And one is to know that kind of pattern of decline in broad strokes that we see. Everybody takes one of these patterns or sometimes two of them superimposed on each other. And then also to look at what we call in our realm here, performance status, which I don't know, it sort of doesn't have the greatest connotation to me, but really we want to know, how's the patient doing in their life? So we have ways that we can sort of measure those and put a number to them. And when we as healthcare providers look at those numbers, we know things are headed in a particular direction. So here is the patterns of decline kind of slide. This shows you, well, I'll first say that almost everybody I talk to, when I ask perhaps about how they see themselves dying or how they would want to die or prefer to die, say, I just don't want to wake up one day. That's what they want. But as you can see, sudden death happens in less than 10% of people. So the whole 90% of us are going through something else before we're going to die. And it's going to be one of these 3 other ways of dying. So this this illness that where you can function pretty well for a long time and then a steep drop off is how cancer goes. So treatment, you're doing okay, things are okay, we're hanging in there, we're coping, we're doing okay, but then suddenly we're losing all the weight, we're not able to participate well in decision making, we're sick in the hospital, that kind of thing. We know when we start to see those things, it's coming to the end of that person's life. That's in comparison to, say, heart disease, lung disease, these kinds of conditions that flare up here and there. And so a person's function is fine, maybe declining because of age, but then they have an exacerbation of their heart failure. So boom, they're in the hospital again and they're pretty sick and really struggling, but it's starting to get better. And as you can see, they just not quite ever get back up to that initial functioning level. And then one of those exacerbations is kind of the end. And nobody can tell which one it's going to be, but we can see time going by, function going down, and we'll look at those function scores in just a minute, and those help us. We put all that together, our knowledge of how these patterns of decline play into a person's function. And we can give you some projection on what we think your life expectancy is going to be that way. And then this prolonged dwindling, we call it, mostly frailty, dementia fits in there. And so you could see with Anita's example how we've got one superimposing on the other as well. So 2 playing together. This is the performance scale that we use a lot in hospice care and palliative care, called the Palliative Performance Scale. We start in the ambulation column to see, is a person fully ambulatory, doing all their normal activities, taking care of themselves completely, eating well, fully conscious. We'd give them that 100% functioning. And then you head down from there. So if someone's starting to have some difficulty, say, ambulating, being able to keep up at the grocery store or walk through Costco anymore, or those kinds of things, they can do some of their own work, but they have a lot of disease that they're dealing with. We know they're still able to take care of themselves. This is kind of where palliative care, specialty palliative care, kind of has that 70% benchmark or below. Hospice comes in even lower. Usually somebody is closer to maybe 50, 60% or below for hospice care. And so you can see people aren't moving around much. They are needing more and more assistance with just taking care of themselves, say bathing, dressing, food preparation, those kinds of things, maybe even standing and transferring. So that is there. And then this is the scale that's used for people with cancer specifically. And as we start to get higher numbers on this, that's when function is declining. And when we see those higher numbers, if we can tell that they're not just temporary because somebody's going through a particularly fierce treatment, but we expect that to work, then as they get these higher numbers, we know that continuing treatment is not going to be a benefit for people when their score gets to the particularly like 3 level. Most people in 1 or 2 are doing okay, but if they're sliding into 3, it's probably time to think about stopping treatment, as long as that's in line with the whole goals of care, we call it. So that's there. And then I wanted to transition a little bit and just tell you about palliative care in case it's something you don't know about, just give you the formal definition of it here. This is on You can find this on what's called CAPC's, the Center to Advance Palliative Care's website. This is, and just about anything you might look up will give you this definition of palliative care. I have 2 slides, so it's kind of a long definition. So palliative care is specialized medical care for people living with a serious illness. This type of care is focused on providing relief from the symptoms and stress of the illness. And the goal is to improve quality of life for both the patient and the family. Palliative care is provided by a specialty trained team of physicians, nurses, and other specialists who work together with a patient's other providers to offer an extra layer of support. Palliative care is based on the needs of the patient and not on the patient's prognosis. It is appropriate at any age and at any stage in a serious illness, and it can be provided along with curative treatment. So you've probably heard that hospice care happens when people are done with treatment, but palliative care can accompany people through treatment and try to work on that stress and strain of the treatment and the illness. This is another way to kind of look at it, Venn diagram, I guess you can, not quite a Venn diagram, a pie chart, not a pie chart. But all of hospice care is palliative care, but not all palliative care is hospice care. So hospice is a subset of palliative care, you can see here. And then this kind of gives you the continuum over time of how palliative and curative treatment might be kind of dovetailing. In more modern versions of this particular graph, that straight line between curative and palliative care is actually wiggly. So sometimes, yeah, we're going, cure's working, we're headed that direction, and palliative can step back a little bit, everything is going fine, but then we may be inching the other way where we have a recurrence of the condition, something like that. And so palliative starting to step in because things have maybe gotten a little worse. When we get to the point where there's no more curative intent, like we were saying before, hospice is a subset of palliative care, so it stays green in our diagram here, but we might recommend a transition into hospice care at the point of no more curative treatment. The objectives of palliative care are to help people, help patients, their families articulate their values and goals of care within the context of their disease process and treatment options. Also to assess, identify, and treat any distressing symptoms using a whole person model of care. And then providing support and education as people travel along one of those trajectories we talked about, assisting patients and families to access supportive resources, including hospice when it's appropriate. So I always say it's never too early to get palliative care involved. So I also wanted to kind of talk a little bit about hope, because I think that hope is something that keeps people in one, very much on the treatment track sometimes. And that's perhaps because hope hasn't progressed as the disease has progressed. So these are transition points in the progression of most diseases that are opportunities for transition in how hope is thought about. So around the time of diagnosis, often I would say that hope is very much for cure. Unless we know it's, we're going to say up front, it's not a curable condition, then the hope is for pushback on the cancer, say as much as possible to give me more time off. And the hope is for more time. Starting treatment, the hope might be for it goes well, I feel well, I'm doing okay. Completing the primary treatment plan, the hope is maybe now that it holds, I'm good, I'm getting move on. And in some cancers, like those ones that we can screen for, find early, we can take care of them and send you on your way with, really cure. And then we may have a new episode of disease or a recurrence. Our hope is going to change here. So you can see how hope changes. Hope is a very personal thing. I was just reading an article about hope, and if you look it up in the dictionary, you'll get maybe 5 or 6 different definitions and suggestions of how it's used. And so it's hard to put an actual like literary diagnosis on it. It has a little more nuance to it, perhaps, and maybe some spirituality and those kinds of things that creep in there. So you may all think about your own hope and how you interpret hope. But there's also this, I think, thought perhaps among our oncology people of if we tell the truth, we're taking hope away. So if you are prepared with your kind of hope transitions, you may be able to push back a little bit when you're talking to that provider. At some point, you may reach the point that we all say this is not curable. Also, you may be able to tell that it's the beginning of the actual last stage of life, and then the point at which dying is diagnosed. So you can see how hope might change in each of these points. And hopefully we'll come back and talk about this a little bit in just a minute. I think I have a couple more slides, and then I'm hopeful that we could open up conversation. Go ahead. Do you want
to do your slides?
Okay. So in transitioning to end of life, these are kind of the things that you might begin to see: withdrawal of the person, changes in sleep patterns, a reduced appetite, becoming confused or agitated. Later in stages, we see skin and temperature changes, bladder and bowel changes, big breathing changes just prior to death, and then the different things that we might observe once death has occurred. So I just wanted you to have this little, these bullet points and let you know that there is a lot more information about each one of them. And I believe that now I switched into resources here. The Passages book that is on the hospice website will bring you through each one of those. So if you go to the Hospice of Humboldt website, which is www.hospiceofhumboldt.org, and you click on what we do, and then hospice care, and then the button for the patient care booklet, and look in chapter 5 and page 48 of that big PDF document. It will walk you through each of those things. So you'll have an idea what that looks like, how to prepare for it, how to support yourself as a caregiver, perhaps, that kind of thing. This is my last slide. And I'm not sure on OLLI if we're able to provide slides, but if these would be of any help to you, I will do my best to get them to you.
Yes, you can. You can
Okay.
send them to OLLI and to me,
Okay.
and people can request them.
Okay. Okay, are you ready? I'm gonna hand this over to Dr. McAtee here, and then maybe we'll have some more discussion.
Yeah, I don't have too much to say. Look at that. I'm Joni McAtee. I'll give a quick introduction. I've been in Humboldt County a lot of years. I graduated Humboldt State in chemistry. I went to UC Davis for medical school. I trained in family medicine in Duluth, Minnesota before I came back here. I am board certified as a hospice medical director. I've been with Hospice of Humboldt since 2018, working under John Nelson as the medical director. I am often boots on the ground and less administrative, so I do a lot of patient care. I also work as a hospitalist at the hospitals here at St. Joe's and Redwood Memorial, which means I take care of people in the hospital, but I'm not specifically on the palliative care team. I am one of the busy attendings running around when I'm there. And then I also work in private practice for family medicine, typically just geriatrics these days. I'm currently enrolled as a fellow through the University of Colorado in a program to become board certified in hospice and palliative medicine, which we are lacking in this county, the board certification, that is. So I'm a year into a 3-year program of doing that. So I'm also a full-time student that way. So I have a lot of hats. being in all of these roles gives me kind of this unique perspective where I can see the good and the bad, and I can see where we're lacking in this realm. And I have a lot of advice, but it's really hard. I think just to plug a book that I think is just often helpful for people. There was a book written called The Art of Dying Well by Katie Butler, which walks through each stage of life and talks about basically how to manage planning for end of life during each stage. And you can recognize through the book which stage you're currently in and plan for the future that way. But there's some pearls in there that are really important that would help a lot of people. There, in our current senior generation, there's a lot of independence, and there's a lot of people who have gone through life taking care of themselves and not put any responsibility for themselves on anyone else. There are, you know, a lot of single people and widowed people. And at that stage in your life, when you recognize that you might not have somebody who would make decisions on your behalf, it's time to ask yourself, who could be that person? When you're well is the time to do that. It's to look at your friends or even acquaintances, people you go to church with, people you go to the garden club, whatever it is, identify a person who you can talk to about getting older and start using the term when I die. I always hear people say, if I die, when I die. And that gets into my other point, which is death phobia. We are a death phobic culture. We don't talk about dying until it's too late to talk about dying well. So we start talking about when I die and what that looks like. And we talk about it with people that we trust, and make friends with your neighbors, whoever it is. Find a person that you can trust. And a lot of people trust somebody who's not their spouse, even with this conversation for one reason or another. I have a neighbor who takes care of the other neighbor despite the spouse, and that's okay. You can be somebody's person and not be their person in their home. But the question is really the advance directive. That's sort of the thing I'm getting at, which is that I'd love for every single person over age 18 to have an advance directive, and very few people do. Advance directives are my love language. It's how I show up at family gatherings with packets in hand, because I have a lot of relatives who need to get these done. And then talking about the what ifs. And the big what if is, what if I cannot communicate? Who do I trust to make decisions for me, and how would those decisions go? What is important to me? And communicate that to somebody now. And if it's somebody who can't have a discussion of what if I'm dying, then maybe it's a discussion of, well, what if you can't talk? What if you need somebody to help with your personal care? What scares you about that? Talk about the feelings. What are you most afraid of? What does that bring up for you emotionally? To try to tease out how to get to the root of it, how to get to the help you might need someday. And the best time to do it is when you're well, and the second best time to do it is when you're not well. And then where I see failings and where things start to get a little bit more tricky is when you're going to the hospital. When you have any kind of disease process, including cancer, and you're at the hospital, number one, your doctor in the hospital typically is not making it a priority to prognosticate. They're not thinking about how long you have. Their main goal is to get you better and get you back out of the hospital. That is our goal. We are, as hospitalists, we have too many patients. We don't have enough time to sit down and have good family meetings. I wish that was different. And when I have time, I do those things. I'm often brought in to do the family meetings when I'm working as the hospitalist because I have this other training. And I often will tell people that they have a prognosis of whatever it is, because I am very well trained in prognosticating. Most doctors are not. I have to ask people permission if they want to know how long I think they will live with their current disease process, but there's evidence and there's signs of things that tell us that somebody is getting closer to the end, even before they start withdrawing socially, before they start dropping weight significantly. One of the big signs is that they're in the hospital too often. They don't want to be at the hospital as often as they are. You're going to the emergency room frequently for symptom management. You're being admitted to the hospital. You're missing cancer appointments because you're at the hospital. In our region, we don't do inpatient cancer treatment. So if you are admitted to the hospital, your cancer care is on hold for the most part. Occasionally, there might be chemotherapy drugs that we can give while you're in the hospital. But if you're being hospitalized and postponing cancer visits for being hospitalized, then there needs to be another conversation about palliation, about what your goals are. Very many people don't realize it's up to them whether or not they're at the hospital. They feel trapped there. They feel like they're a prisoner there, that they're at everybody else's whim. The patient is the boss. They are in charge of whether they go home or not. Another important thing is that people who live in nursing homes or assisted living facilities, group home kind of situations, in order to avoid being in the hospital, they usually have to have a palliative team on board and potentially even a hospice team on board, or the staff at that facility cannot keep them home with certain things going on, like low oxygen levels. If somebody would prefer to stay home with low oxygen levels, we should be getting palliative care or hospice care on board. So our hospital teams don't always prognosticate. Not even our palliative team will necessarily tell you that you're dying unless you ask. So they also have too many patients, unfortunately. And it's helpful to know what you want to know, because they might not ask you if you want to know. And a lot of your doctors will assume you know that you're dying. Or they might assume that you know that you're in your last year of life and you don't. And it's hard to be wrong. It's hard for the doctor to want to guess and be wrong too. So telling them, how long do you think I have left? And don't anchor onto one doctor's opinion, because nobody has the ability to tell you exactly how long you'll live. So you might get multiple opinions, and that'll help you understand that your case is confusing and maybe we need to figure something else out. We often admit people to hospice who are on hospice for longer than 6 months. That's because we don't have the perfect guesses on how long a person will live. It's often my advice that if we qualify you for hospice, meaning you meet the criteria according to Medicare to have hospice on board, then I like to have people get onto hospice, because you get so much more support. You get this big team of people. You get a nurse, a chaplain, a social worker, a home health aides. There's so much extra care that people get when they come to hospice that a lot of times they get a lot better. It's the paradox of hospice here, is that getting on hospice often helps people get off of hospice because their care is so significantly better than it was before they got with us. We have an amazing team, and everybody on our team works so hard. And a lot of our patients do very well that way. And a lot of patients die, and they die well, and the art of dying well is what I'm getting at here. Recognizing it and talking about it, those are the biggest things. So I went through my list. I think.
Nice.
One of the questions is, basically, do you have grief groups or counseling groups or
Do they
private?
ever? Yeah.
Yeah, hospice does. For hospice, for people who've been on hospice, they have a lot of grief support. For people who were not on hospice, say your person maybe died for being able to get on hospice, for example, there still is some community grief support. It's maybe not as robust, but yes, definitely worth a call to hospice to check it out.
Is that routine like regular groups or individual counseling? What is it?
For the second sort of people, the second example, like if your person
Yeah.
did not die on hospice, yeah, it's not individual, it would be group.
So you have that routinely, like once a week, once a month, once, how's it work?
They do.
Okay. Because that would be helpful, I think, for people. But I think we have a person interested in basically saying, I'd like to have more discussions about death and dying. Perhaps we could do a class on that. We'll talk about that for the fall. because I think it is a subject we all need to understand more about. Any questions from any of the rest of you that you'd like to hear more about?
I think Ellen had something she wanted to talk about
Just
also.
wanted to add, I'm still kind of haunted by your story, Jane. And, you know, one of the things about medical care these days, it's under a lot of pressure and we don't have enough people working in it. There's plenty of money in the system, but it's not getting down to the frontline patients and doctors. It's going out to medical device companies and pharmacies and pharmaceutical companies, I mean. And it's in one career, I've seen this kind of all fall apart where you have, you know, the trusted advisor seems to be gone. And part of that too is because medical care has gotten so complex. And in order to do your part of the case well, you've got to be trained differently and you have to keep up your skills differently. So from the patient's point of view, that can seem like an awful lot of fragmentation of care. The other thing is that, especially in an area like this, some people who are taking care of you live here and are members of the community, and some people don't live here. They're just up here doing a contract job. But remember at all times, and this irks me, this is my big message, is that you always have more than one medical care provider. And hopefully you've clicked with one of them. And even if your patient is in the hospital, if you clicked with the radiation oncologist or you clicked with the surgeon, call that person up. You know, we don't have yellow pages anymore, but you know what I mean. You know, get their phone number, make a personal appeal saying that you're having trouble, you need some help. Another thing you can do if you don't have a person like that is to put in a request to have your case discussed at tumor board. Joni and Karen are always on tumor board with us every Wednesday. And we have everybody who treats cancer in this area, plus are on that discussion so that we all bring in our ideas about how a case might be handled. So there are resources. To get on tumor board, you'd call the cancer program at St. Joe's and just talk to the nursing director.
Okay, we didn't talk yet about doulas.
Okay, death doulas.
There are a few in Humboldt County that I know. That's not part of what the hospice provides. So someone might engage the services of a death doula if they wanted to have that person present, say, through their death. But sort of like a birth doula, or in that, you know, in that sense, just accompanying a person through their final
Yeah,
time.
can I add something?
You know about that too.
So
Mhm.
death doula is a formal training, and there are a few people trained in death doula in our county, and that's a paid service typically. However, the idea of a death doula, much like a birth doula, is somebody who has experience, who can walk you through the stages. A lot of that is done just naturally through hospice roles, but the best death doulas I've ever met are people who lost a spouse or lost a loved one, took care of their mother, know the system, have dealt with death and did pretty well with it. People that I tell them they should come work for us. You know, they often find themselves in the role of using that death and that grief and sublimating it and helping other people. So going out and helping friends or becoming a hospice volunteer. A lot of our volunteers will do something called sitting vigil, which is when somebody has nobody else and they're in the end stages of life, then the volunteer will go sit at their bedside and just be a presence. But they also are trained, much like a death doula, to understand the stages of death and to be there as a support person. So really the best death doulas I've ever seen are friends who know what they're doing. Yeah.
We also didn't discuss the California.
Oh, the maid.
That was my last thing.
Yeah.
Yeah, okay. So yes, in fact, it's important to mention that that's a law that started in Humboldt County because Patty Berg carried that bill. And the year that it came up before the legislature, my husband was president of the California Medical Association and managed to get their support behind the bill for physician-assisted end-of-life care. Some things that have to be remembered about this. First of all, it's supposed to sunset, but there's a bill before the legislature now which will make it permanent. Otherwise, it's sunsetting in 2031. It's doctor assisted, and what you're really doing when you ask your doctor for this is you're asking for a prescription that you can give yourself that will end your life. The requirements are that you be a California resident, that you're competent, and that you have a prognosis of less than 6 months. And one thing I add in there is after that 6 months, will people be able to actually administer the medications themselves through some GI tract route? But it's a compassionate option. Every time I've been involved, it's been a peaceful death in an otherwise really hopeless situation that has suffering coming up in it. It requires that the patient makes 2 oral requests at least 48 hours apart, and that you sign a written request. 2 doctors have to certify that this is the right thing to do. And alternatives were discussed, including hospice and palliative care. It's always there. But besides administering the drugs, you got to pay for the drugs because they're often or almost always not covered by insurance. But for those who can qualify, who have a terrible situation, it's a reasonable thing to do to avoid suffering and to avoid the strain it puts on families when somebody suffering is there all the time. I think that one of the biggest gifts of my job and my career has been that I don't get to not think about death every day. And it adds a certain sweetness to life to realize that it's all finite. It's been one of the privileges to care for people through this transition, as I know it is for my 2 partners here.
Let's see, my comments. Tomorrow is the hearing for SB 403 that would make California End of Life Option Act permanent.
Oh, good.
Did you say SB 403?
Yep.
SB 403, yeah, that's the
Actually,
one.
yes, tomorrow.
I'll just say at Hospice of Humboldt, we do have patients that use the medical aid in dying medications. We don't prevent them. Our doctors and nurse practitioners are not the prescribers, and our nurses are not required to participate. However, typically we're supportive with the family. We can be there and sort of handle a lot of the logistics and support the family as they go through that and the patient. And so it happens fairly often that one of our patients will go that way and we can be helpful.
We do have
Well,
a
that's encouraging
lot of
because
education.
go ahead.
We have a lot of education. We have some of our staff members who've been very interested and wanted to know as much as they can. Have attended national conferences, that kind of thing. And we're very, we know how to get people what they need or what they want if they're interested in getting evaluated for qualifying for the End of Life Option Act, medical aid in dying. So usually it's not something we necessarily suggest to people, but we get a lot of questions and we do not shy away from those at all. We talk very openly about that. We want to help people die well in hospice and in palliative care. And if that for them means accessing medical aid in dying, then that's what we're going to do.
There's also something that I failed to bring up earlier where Tracy Barnes Priestley asked me to please mention to you that there's going to be another Boomer Troop show on May 31st and June 1st. And we haven't had one for a number of years and they're a lot of fun. So that's just a little pre-announcement. So you might watch out for it because they are a great deal of fun. They've typically been at the Eureka Women's Club. So keep your eye out for it because it's a lot of fun. Song and dance, and it's creative for seniors, and our local seniors participate in it and have for a number of years, but we haven't had one since, I don't know, COVID, which is no surprise. So does anybody else have any particular questions?
Yeah.
Jane.
Yeah, this is a little hard because it's my sister, who's since died, was she lived on the East Coast. She didn't want to talk about it. She was diagnosed, and I found out after she died that she was stage 4, and the oncologist even told my nieces that they couldn't tell it metastasized so much, they couldn't tell whether it was, what kind of, where the cancer had started. So, and I couldn't do anything about it because she wouldn't talk about it, but she had an oncologist who just kept doing more and more chemo, even when she was getting sicker and sicker. And it was really horrendous to watch. And my sister, I mean, I know there's nothing you can tell me to do, but I just had to say it out. And my sister called me 2 days before she died, and she said, "Am I doing this too fast?" And I said, "Do you mean your dying process?" And she said, "Yes." And I said, "Ansley, your body's so tired. You've been working with this for 2 years and you're tired and you need to go." And she died too. And then she said, "Well, I better talk to the doctor and ask her if it's okay." So I'm just talking about the sometimes sick relationship that you might have with your oncologist. And there's nothing I could do about it. So I'm just still frustrated. I had to just say it out, but so I'm sorry, it's not very helpful. But
Maybe it's comforting to know that we have actually a program to start talking to the oncologists, especially the ones that aren't here permanently, to talk about this very issue. Because when they're under time pressure, for instance, or they're afraid of the emotion that might be stirred up or whatever, and they're already tired, they will often just, okay, another treatment. You're right. And it's not the right thing to do. And the nurses and I have formed a working group together, and we're going to sit them all down and talk to them, and then have some kind of ongoing way of having the staff alert the doctor that they've watched this patient for over a period of months and they're not doing well.
And she even she got so bloated, they took her in, had to take her in several times. And the oncologist at that point said, "Oh, I think I've got another kind of chemo that will work." I mean, how could you do that? It just seemed almost malpractice to me. Anyway, Ellen, I really appreciate that. That's so, if you're
No,
Dr.
we're working on that.
Thank
And you know, the radiation oncologists here all live in the community. The medical oncologists tend not to live in the community. And medical oncologists are the ones that you want to have be, warm and fuzzy. And there are very few warm and fuzzy medical oncologists in the whole country.
Right.
You have to pick your advocate, and often it'll be a nurse in the clinic or an advanced practice clinician or somebody, and that team that you could talk to at branch points, because
Well, I would have done it. I mean, I would have no
Yeah.
problem, but it was so hard because my sister wouldn't.
No, nothing on you. I'm just trying to make it better here.
Yeah, no, I really, really, really so appreciate your doing that. Thank you so much.
And sometimes it doesn't make any difference whether somebody's warm and fuzzy or not. We worked with my husband's oncologist for almost 25 years. I mean, he was supposed to die within 5 years, and 25 years later, he finally did. So we developed a very close relationship with her, and she knew that he also had Alzheimer's, and that the prognosis, even with the Alzheimer's, was very slim. And still, toward the end, encouraged him to get an additional treatment, because there's always something new and exciting happening in the field of oncology. And she meant well. It didn't help. It was very cumbersome for me. It meant driving down to Stanford, every 4 weeks, and then driving him back home radioactive, just so that I wouldn't contaminate a motel room for some poor housekeeper that was pregnant. Even a well-meaning oncologist who's kind and who is able to acknowledge that death is coming, sometimes they can't help themselves. It's hope. This is where the hope that Ellen was talking about comes in. You have to hope for the best, but you certainly need to plan for the rest of it.
Yeah.
We remember that hope is not a plan.
I will second that, because basically we went through the radiation. That seemed fine. It was getting better. And then we had 3 treatments, because it was a new combination of drugs, and the drugs were fine. It set him back each time for a few days, but then he was getting better. Everything was shrinking. That was good. but he was so malnourished at this point that basically it's like he got a virus. We don't know whether he got it when he went in for treatment because the people coming in weren't required to wear masks, but he got a virus and it took him down in 10 days because he had no immunity left. So these are things that, I mean, it would have been very helpful to have somebody sit us down and say, stop this. You know, this is crazy.
Yeah, just, you know, I would just recommend seeing if you have a palliative care program in your area that might help you out too. I have attended visits to the oncologist with patients before to help them voice their concerns. And, you know, sometimes there's a little bit of, I don't know if it's fear or just not wanting to disappoint somebody by saying, I'm done. I don't want to do this anymore. That kind of thing. So we really encourage, we want to empower people to really speak their truth and to really, you know, examine within themselves what their truth is too, so that it's easier to speak. But
I have a question. Can you hear me?
yeah.
Sure, we can.
Yeah. This is actually, my mother is 106 years old, and she's in a family home where they care for her. And I just heard before this discussion started that she may have had a small stroke. My question is, I hate to send her to the hospital and set off a train of events that we don't have control over. What is the obligation? I also have a husband with a terminal illness, and what is the, I don't know what to do. Do we, when things get really bad and they're at peace, do we just
Let him
let
go.
them be at peace?
What does your mother have to say about it?
She she has dementia. Yeah.
Yeah, in my experience, your return from going to the hospital is going to be pretty low. It's going to be a low value thing for you.
Absolutely. She's real. I
And
just
if-
think it would be a real mistake.
It sounds like you're in a palliative, not curative approach, and so just focusing on her comfort and how
That's
she.
right. That she's just in a situation that's ideal, and we want her to die at home. And I'm going to go up there after the class.
We don't have any obligation to take her to the hospital.
That's my question. God bless.
From the doctor's point of view, we don't have to treat everything. And we can sometimes pick a more peaceful route out. You know, one saying is that pneumonia is the old person's friend, meaning that often takes people out and relatively peacefully. So we don't have to treat every infection. And so we will sometimes with the family make that decision as a way of letting things go. We're not obligated to bring out everything we have all the
Yeah,
time.
and the family's unified in this.
Yeah,
But
we
she's
can
got a wonderful
always,
life. She's
always
happy.
focus on comfort though.
Yeah.
We can
Well,
always.
thank you so much for doing the work that you do, and I will get off the air and go see my mom.
That's good.
Thank you,
Thank you so
Michelle.
much.
I have a question.
Yeah,
Can you hear me?
yes.
Mhm.
It's Claudia. My dog Katie was a bloodhound therapy dog for hospice, and I want to know if hospice has ever gotten any more therapy dogs, because the patients that we visited at Timber Ridge and at hospice really gained from having those dogs come into them.
We do. We
We
have therapy dogs.
always have the.
We have them at the hospital too.
Wonderful. I'm just very happy to hear
You're
that.
right. I'm so glad you had a dog like that. That's great.
I'm raising an 8-month-old puppy right now, and I'm hoping she's going to eventually join therapy dogs.
Good, Claudia.
Yay, that's awesome.
Thank you.
Any other questions? No?
Okay.
Can I make,
Well,
a- whoops, I unmuted. This is Debbie Hartridge. Can I make a comment?
Sure.
Sometimes there's pressure from people other than the person, i.e. in my experience with my mom, she wanted to go home from the hospital. This was at St. Joe's about 13 years ago, and she'd had enough. She'd been in the hospital for 2 months, and I won't go into what all was going on with her, but she just wanted to go home, and her surgeon wanted to operate again, and my dad wanted her to have another operation. And but fortunately, she was very lucid, very clear, and this all came out in a meeting at the hospital that was held by the palliative care doctor at the time, for which I am eternally grateful, because it gave a chance for people to weigh in, and my mom to weigh in front of him, the palliative care doctor, the surgeon, my dad, myself. And I just, that idea that kept in the hospital, if they were not able, I mean, if she had not been so able to articulate what she wanted, this kind of thing is, I'm sure it happens sometimes, her husband didn't want her to go, her doctor thought he could fix things, she'd had enough. She was 80.
Yeah, I'm so glad that that opportunity to discuss it in that group setting happened. That really is a great thing. I think that's what we love about our work here at hospice, is the team approach to things and really involving the family and the people who love that person. Can really help people to align their goals with what they want to do in life, their goals, where they're going, what they're ready for with their treatment. Those two things need to be headed in the same direction. So I guess I could stop sharing. I so apologize for.
Here's my therapy dog. I have one, and he's wonderful. I would recommend everyone, if you as you age, if you get a dog, they get you out for a walk at least twice a day. It makes you, you don't want to just turn them loose in a dog pen. You makes you get out in the morning, and there's your therapy cat.
Yeah, a therapy cat. Yeah, I have 2 rescue dogs that need therapy.
Well, it's a lot of TLC, and they're very giving. Yeah. And they get you to play with them even when you don't feel like it. And they're wonderful.
That looks like a multi-poo. Is that a multi-poo that you?
I think, yeah, it was presented to us as a puppy, as a poodle, right? And it's like, well, no, there's way too much hair. It's not short enough, and he's a little too long and a little short-legged, but he's wonderful. I don't care.
Us who were waiting at Sunnybury Medical Clinic for our veterinary appointment had a group discussion in the waiting room about the best dog for cuddling, and the consensus was multi-poo.
Oh, he's fabulous. Absolutely fabulous.
Bloodhounds cuddle pretty nice.
Well, I'm sure they do. Katie was a great dog. I remember Katie.
And Ladybug is literally saving my life after losing my husband and Katie. I mean, this little girl came into my life in November, and I found love again.
Yeah.
Yeah, it's amazing. He got elevated from the floor to the bed, to the foot of the bed.
Yeah. Well, that's another lesson, life goes on, and it's hard to tell that to somebody in the family who's going to survive a death they never wanted to have happen. But there is life. There's good stuff after this.
Well, and basically, OLLI kind of saved my life, because I had to put together the brown bag lunch program. I had to continue it throughout all this, and then put it together for the summer, and working on courses, and
sure.
I couldn't just stop.
Well, I'm glad you didn't.
Got a purpose.
I haven't.
Thank you for the opportunity for us to speak to you. That was it was great, and I thank Joni and Karen for agreeing to come on too. I think I figured they had the most experience and people that I trusted to give the message and to give all the viewpoints.
And I would like to meet with you to discuss maybe a program we could put together through OLLI or in combination with OLLI. Okay. Because clearly it's a discussion that's pertinent to a lot of people.
All right.
Be happy to do it.
Thank you so much, you guys.
All right.
Absolutely.
Bye.
Thank you.
ever so much.
Back
We'll
to
look
work.
forward to seeing you again.
Back to
Take
work. Okay, bye-bye.
You take care.